Welcome to UOA On Demand. I'm Dr. Stephen Kayiaros, and I'm joined today by my friends and colleagues, Dr. William Baione and Dr. Andrzej Brzezinski. And today we're going to be talking to you about joint revision surgery, which is when we have to do an operation on a joint replacement that has already been done that has sustained some sort of mechanical failure. Now, this is quite a large and broad topic, and so we will try to um, uh, uh, narrow it down so that we cover the scope of the topic without getting into too many details. Now, I'd like to start the conversation by talking about, in general, why do joint replacements fail for mechanical reasons. I'm going to ask my colleagues to avoid about talking about joint infection because I think that that's another separate topic that we can spend another webinar on. And so I think we should focus the conversation on mechanical failures, longevity of implants, and why these joint replacements sometimes have to be reoperated on. So, Will, why don't we start with you? Why don't you tell us a little bit about some of the more common reasons why joint surgeries may need a revision?
Thank you. We're going to jump into the topic here. And, as you had alluded to, joints fail for different reasons. And when you look at the mechanical reasons, I think if you try to classify them, you can break them down into kind of early failures and late failures. And sometimes you can divide those things into things related to how the joint replacement was done. If we're talking specifically about hip replacement, there's certain variables that we try to achieve when we perform the operation, where we try to place the implant in a position that matches the natural anatomy of the patient. And so one of the common mechanisms of failure that some joint replacements experience, specifically hip replacement, is something called instability, or what can be referred to as a dislocation. And that is essentially when the prosthetic ball of the hip or the ball of the hip socket pops out of the socket. This is a traumatic event. And when it happens, it's often something that requires an intervention to get the hip ball back into the socket. There's a number of reasons why this can occur. We can then divide that into how the operation was performed. There are different approaches that are used to perform the surgery, whether or not you're keeping or detaching muscles from the hip. In the more traditional approaches where you're cutting through some of the muscles either on the side or the back of the hip, you're creating a little bit of instability to perform the surgery, and then you're repairing those muscles. And so in those cases, you perform the surgery and the patient can have a very good outcome. But during their initial recovery, they have to protect themselves from certain motions. And this is what is referred to as hip precautions. And so there are some situations where in the early recovery from the operation, either a patient has an event where they bend or they twist in a particular way, they sustain a small fall or trauma, and the hip can pop out of the socket. And in those cases, you can blame that on a sort of a mechanical positioning of the hip. And if you can reduce the hip and protect it, sometimes it can heal. But unfortunately, there are instances where these replacements, once they dislocate once, can continue to dislocate. And so if you have a hip that's popping in and out of the socket very easily, that is one type of mechanical problem where you would have to perform a revision to try to make the hip more stable. And so that's one mechanism of failure. Another subset of sort of early failures that sometimes we can see, which can be often its own topic, are fractures that can occur. And periprosthetic fractures are ones where the implant is placed within the bone, and sometimes a fracture can be sustained at the time of surgery that's not recognized, or sometimes can happen afterward. So there are some situations where the implant unfortunately can become loose due to a fracture. And so now you have a situation where the actual fixation of the implant is not stable. And this is another situation where sometimes you have to do another operation to basically fix or put in a new type of implant. And these are two common things that we can see as early modes of failure in hip replacement. I don't want to monopolize the whole discussion, so we can kind of chat about those two things, and then we can touch on some of the other revision topics.
Thank you, Will. I think that's a good way to open this discussion. Dislocation and total hip. Fortunately, it's not very common, especially with the direct anterior approach with preserving muscles, but still, dislocation is still one of the most common reasons why hip replacements have to be revised. And so I think one of the concerns that patients have who need this type of revision surgery is, well, how are we going to make the hip stable again? And one of the technologies that I like to use is something called dual mobility. And maybe, Andrzej, maybe you can talk to us a little bit about dual mobility technology and how that has helped surgeons tackle unstable hips.
Yes, so dual mobility is not a new concept. It was developed in France in like 70s. And the idea behind that was to prevent dislocations of the total hip arthroplasty. And at that time, the implant that we have, that was the stem that was placed in the femur and the cap, and it was connected by the femoral head. And the size of femoral head was pretty small. It allows for good range of motions, but it creates situations that in extreme of range of motions, this implant can dislocate it. So idea behind the dual mobility was to create the bigger head that's prevent from dislocation. So the developers add extra piece of implant, we called it like larger head or plastic head that was articulated with the cap and was connected to the smaller head that was placed on the femoral stem. That allows the patients or the hip for increased range of motions. And it was significant increased range of motions before dislocations, estimated for about 30 to 40 degrees. And this implant was revolutionized the total hip arthroplasty in Europe in 70s and 80s. And this implant has a good longevity, has low risk of dislocations, low risk of complications, and was utilized it was very popular. In about 10, 12 years ago, this implant came to the United States and was utilized mostly in the revision total hip arthroplasties. A design of the implant that is used now in the United States is a little bit different than the original design from Europe. And we call it modular implant. So it's allowed to place the acetabular cap that can be fixed to the pelvis with the screws and accommodate to the rest of the implant by placing metal insert that connect two heads that's moving separately on the femoral stem. And this design is great and allows to perform revision surgery and has low risk of dislocation. However, there is one thing that is related to this implant. The connection between two metal elements can create some micromotion between them and can release the metal ions that can create some situations. We call it pseudotumor or metal-on-metal reactions. That is not the situation that is optimal for the patient and sometimes can create some problems.
Yes, thank you, Andrzej. I think that's a very good overview. The way I like to describe it to patients is that it's like a double ball bearing. And so the advantage to the dual mobility is that you get a very large head, which lowers the risk of a subsequent dislocation. Great. So I'd like to shift the conversation now to the technology of the implants that we use, because one of the things that can happen in a joint replacement that has been implanted for several years, decades, is that the the plastic piece of the implant, whether that's in the hip or the knee or the polyethylene, starts to wear away. And that wearing can cause bone loss. It can cause the implants, which were once very rigidly fixed to the bones, to become loose. And so there's a wide spectrum of types of revision surgery that we do. So Will, if you can maybe just talk to us a little bit about the spectrum of the revision surgeries as it relates to the wear of the plastic bearing.
Yeah, I think this is a great topic. When we talk about joint replacement, I think one of the things that we have the benefit of is that we have good materials that now last a very long time. And so as we see younger patients now, a lot of the growth in joint replacement, you see a large proportion of patients that are in that age group of 50 to 65 that now are undergoing joint replacements, where years ago, if you were younger, I think there was a real resistance and they would make people hold off. And that comes down to this question exactly, that you basically had a bearing, which is a piece of plastic, which is polyethylene, that would only last a certain amount of years. And there was a time where it was like 10 years or 12 years. And as you alluded to, it wears out at a certain rate. And a lot of that had to do with our understanding of how we manufactured the plastic. And the way I explain it to patients, it's often like, it becomes like a snow globe inside of the hip, where these small little particles are released into the joint fluid. And there's this concept of what's called the effective joint space. And so when you look at early hip replacements, when they used to be cemented to the bone, you didn't have a very rigid fixation like a bone that has grown into the implant. And so this snow globe debris or the osteolytic debris that would develop would create almost an autoimmune reaction, where the immune system would eat up this plastic. And as a result, it would travel around the interfaces of the implant. And so this is why plain x-rays and routine follow-up for joint replacements is important, because we can often identify some of these earlier signs of lucency or loosening, where you see these gaps or places around the implant that can be worrisome. When it's very, very far gone, we see crazy things like the entire cup can wind up inside the pelvis, or you can have a stem that's subsided. And so the idea is that when the patient presents, sometimes they can have osteolysis and early signs of the implant becoming loose, and they could have no idea at all. The classic x-ray that we look at in hip replacement is a ball that's sitting inside the socket, but it's no longer in the middle of the ball. It looks like it shifted a little bit north, and we refer to that as eccentric polyethylene wear. And so it's like a ball that's rattling around in the socket. And this doesn't always cause pain. And so if this goes unrecognized, sometimes patients will present with an instability event or fracture. And so the way that we address this problem is we identify where the problem is. And so if it's been long-standing, the bone will lose its quality and its attachment to the implant around the interface of the component. And so the component itself can become loose. And so what we try to determine is the implant that's in place in good mechanical position? Does it appear to have sufficient fixation to retain it? And so in those cases, sometimes if you catch it early enough, you can just go in and replace one of the modular pieces. You can take out the old piece of plastic, put a new piece of plastic in, a new head, and save the hip. But that situation, sometimes getting the plastics out and some of the mechanisms that were around to lock the plastic in are archaic and not as good as what we have today. So in many situations, we will use our judgment based on the quality of the bone and what's going on, and we might choose to change one part or both parts. Sometimes you'll take out the cup and then you'll retain the stem. Sometimes you'll take out both. And then you also need to have a plan B, where if the implant that's in place, once you get in there, there's something wrong with it. It's not positioned properly. The taper that you thought was going to accept the head that you need doesn't fit. The plastic liner doesn't work. Then we go in prepared basically to do everything that needs to be done. And the goal of that type of surgery when there's bone loss is that you try to attain stable fixation. But the difference this time is because you've lost bone, you often have to supplement these areas where the bone loss is. And that's where the equipment gets more complicated, where we use specialized equipment that has additional types of material referred to as augments. We use screws. Sometimes we use these very elaborate implants that have cages. The stems that we use within the femur are typically longer. Sometimes they're modular, but they give us the versatility to tackle a problem intraoperatively. And I always say, or one of my mentors used to say to me, kind of like Confucius, like know your enemy. So you want to know what you're dealing with before you go in there, because if you're unprepared, then a revision can go poorly.
I couldn't agree with you more, Will. I think, fortunately in our field, we have a lot of, the technology, I should say, has advanced such that we have a lot of different implants and tools to address these complicated cases. I mean, I think recently had dinner with some folks from this small company, actually from New Jersey, that's doing custom 3D printed triflanges now, which is a special type of implant for hip replacements with a lot of bone loss. So it is exciting that these technologies are now available to us, where in previously, as little as 5 or 10 years ago, we didn't have these technologies to address these complicated cases. One of the more common questions that I get from patients who have had a hip replacement who need a revision, they say, well, my hip was done through a posterior approach. Can I have my revision done through an anterior approach? And so I think with the popularity or the increasing popularity of anterior approach hip replacement, that has now extended into the revision arena. So maybe Andrzej, freshly trained at a fellowship, he was fortunate enough to do a fellowship that was very heavy on anterior approach exposures. And so maybe, Andrzej, you can talk to us about revision surgery through the anterior approach.
Yeah, so, the simplest answer to this question is yes, we can do revision from anterior approach. And in some centers, for some surgeons, there's preferred approach for the revision. There's some benefits from this approach. There's some advantages that we have from this approach. There can be some complications that are related to this approach, and we have to consider that when we pick the right approach for the patients. I would say there is no one universal approach for every surgery, and it should be adjusted to the patients. Some patients can benefit from anterior approach, some patients can benefit from posterior approach, and it depends on the problem that we try to fix, depends on patient's anatomy. Anterior approach is a very good approach with very low risk of dislocations. And the main problem with revision surgery, main complications from the revision surgery is dislocation. So we try to fix the problem with the surgery who has inherited higher risk of dislocation. And choosing anterior approach when we preserve all the muscles in the back of the hip is beneficial for the patients. We're not cutting all this muscle. We're going anteriorly through the interval, which is naturally developed between the muscle. We're going down to the hip joints, which is very good approach, and probably the closest distance to the hip is from the posterior approach than any other approach. We have good visualizations to the acetabulum, and this approach is great for the fixing acetabular problem. Some challenges are related to the fixing problem, which is on the femur. If we have to address the femur, this approach may be a little more challenging because the muscle structures around the proximal femur, the nerves and the vessels supply to the proximal femur makes this approach more challenging because we have to be very careful not to injure these vessels or nerves. And also, approaching to the femur from anterior approach is a little more difficult than from a posterior approach. From the posterior approach, we get a straight view on the femur. From the anterior approach, the femur needs to be released, lifted up so we can see entire proximal femur very easily, so we can safely put the implant. And that can be a little challenge. We have extended approaches that we can extend anterior approach down to the femur, and then we can fix all the problems on the femur, but this requires a little bit longer incision and a little bit extensive approach.
I couldn't agree with you more. I think there's no, at least for revision surgery, that I don't think there's one good approach or one approach that's superior than the other. And I think there are certain cases where an anterior approach is more advantageous, and there are other cases where a posterior approach is more advantageous. And so approaching these cases on a case-by-case basis, I think, is a good way to tackle the problem, fix it, and do what's best for that patient. Well, I think that's a very nice, concise talk on a very broad and elaborate topic, joint revision surgery. I want to thank my colleagues, Drs. William Baione and Drs. Andrzej Brzezinski, for joining me today. For more information on joint replacement surgery or any other musculoskeletal complaints, be sure to visit our website, www.uoanj.com. And thank you for joining us on UOA On Demand.